Welcome back to those of you who have been with us all day. Well done. And hello to those of you who have just joined for this session, which, as the programme shows, is a talk on COVID-19. Kidney doctor's perspective, it's hard to say that. And so we're delighted to have Professor Paul Cockwell here today, who is a consultant nephrologist and also Professor of Nephrology at Queen Elizabeth Hospital Birmingham and the University of Birmingham. After Paul's talk, we're going to have a sort of a quick Q&A session, so hopefully pick up on some of the questions that we've not been able to answer so far today.
Thanks very much, Jane. Good afternoon, everybody. It's great to have the opportunity to chat with you all this afternoon. And what I'm going to do is really take a fairly flexible approach to this. I'm going to try and be agile. Never believe a Welshman when he says he can be agile, but I'm going to try and be agile and look for you to direct me to a certain extent about what areas you want to talk about. So I will keep an eye on the Q&A chat. Some things are coming in already, and perhaps we'll pick up from some of the questions as they come in there. And I'm also then going to try and cover some of the things that have gone on in this particular period of time. There's been a lot of things that have clearly happened in the last 8 months or so that go beyond COVID in terms of the changes in models of care that people who've got kidney disease are encountering. And I'm going to talk you through some of those from a clinician's perspective. And also we shall open that up and you'll be able to ask some questions and perhaps give me some feedback from a patient and carer perspective on what things are really important in this period. We've got a real onus on us collectively as a community at the moment, because we've really got to find our way out of this period of time in as good shape as possible. And that's going to be challenging to do because there are a lot of competing priorities in the health system. And whilst many people have kidney disease, there are a lot of other major disorders which to a certain extent have a bigger place at the table than we have in terms of defining resources and in terms of defining structures, and indeed in terms of some very practical things in this period, including, for example, ensuring that we've got availability of the vaccines. And we'll talk a little bit about vaccines because that's incredibly exciting news, and that is the way out of COVID. There's no doubt about that. And those have come through quickly and may well mean that in 6 months' time we'll be in a very different place to where we currently are. But why don't I just give people a feel of where things are at in terms of how renal services are working across the country. And so if you go back to March and April, what happened at that time was that services were overwhelmed in a very short period. So the numbers of patients coming in with COVID got up to around, at one stage, 20,000 people presented to hospitals in the UK a day, and well over 1,000 people a day were dying by the middle of April. And one of the things about kidney services is that a lot of people who work in kidney services have multiple skills, and they can work across in other areas such as intensive care units and in acute medicine. So many people were moved out of the areas they were working in, firstly. And then secondly, particularly in dialysis services, there was an enormous amount of pressure because there was a lot of COVID-19 infections in dialysis units, and there was a lot of staff sickness. And as a consequence of that, dialysis services, many of them had to decrease the amount of dialysis that they were providing, maintaining safe dialysis, but dialysis below that level at which one would usually prescribe. And then other staff were being rapidly trained up to deliver dialysis care, and people who who are on the call who receive dialysis, particularly people who receive in-center or satellite dialysis, hemodialysis, will recognize that the skills of the staff who provide hemodialysis is a very, very distinct group of skills. And that put a hell of a lot of pressure and stress on renal services. The fall off in numbers through May and April was rapid, and that really did lend itself to recognizing how effective the lockdown was in getting on top of the first wave of the pandemic. The challenge with the first wave of the pandemic was that clinical services came very close to genuinely collapsing. The biggest example of that was in the intensive care units, where virtually all the major intensive care units in the big towns and cities were way above the numbers of patients that they are set up to be able to deal with. So there were 2 to 3 times as many people in intensive care units, and usually the case, a lot of staff sickness, and equipment was getting very short, such that ventilators were being imported from other countries because there were shortfalls in ventilators, breathing machines to put people on. In terms of kidney failure in the intensive care unit, what rapidly became clear was about 1 in 4 people with COVID-19 who got sick, such that they needed to go to the intensive care unit, had severe kidney failure. This is people without kidney disease going into the intensive care unit with COVID. And as part of the illness, the kidney stopped working. And we effectively ran out of the specialized dialysis machines for the purposes of treating people with kidney failure on the intensive care units in the UK. Some of that hit the press, although it didn't hit the press in a way where it became clear that there was a crisis to the level at which there were no more machines left. And as a consequence of that, there was a lot of very rapid support with, thanks Jane, with kidney services going into the intensive care units and giving short hemodialysis treatments to people with kidney failure on the intensive care units. Can you imagine that? People are on the machine. There's all the personal protective equipment required for the purposes of trying to limit as much COVID spread as possible. They were incredible places, and you'll have seen photographs of the way that intensive care units looked through the first wave of the pandemic. And then into the middle of that, renal services were going and were setting people up for short hemodialysis sessions, always setting people up to start peritoneal dialysis. There may be some people who are on the call who are receiving peritoneal dialysis or have received peritoneal dialysis treatment, and that's treatment where you have a very a thin tube placed through the front of the abdomen, front of the belly, into the abdomen, with fluid going in and out, which removes the waste products that the kidneys can no longer remove. And it's been 30 years since we used peritoneal dialysis acutely on intensive care units in the UK, and in some centres we started using that again. So there was incredible stress, and the whole of the intensive care acute kidney injury area got that close to falling over. And that's one of the reasons why there's a need to focus on the ability of the NHS and the capacity of the NHS to be able to manage COVID-19 patients coming in with that. And one of the big discussions that we're clearly having at the society level is this tension between the limitations that are being placed on us that ramp up for periods of time and then come back down again. Well, what is all that about? Well, for me, it's about 2 things. It's firstly, it's really protecting the most vulnerable people in society. But secondly, it's about protecting the capacity of the NHS in the round, because one of the challenges with COVID-19 is that it could overwhelm certain parts of this health service, such as with critical care, but also as a consequence of the impact of COVID-19, we're unable to provide care for all the other medical problems that are non-COVID-19 in a way that we would usually do. And as we all know, the NHS is a very tightly funded service. If you look at the proportion of the gross domestic product for the UK system compared to systems in comparable countries in Europe, we probably put 2 to 3% less of our gross domestic product into our national health service as opposed to the health services in other countries. And that means that it's tight. Capacity is right up to the wire. And COVID-19 has really exposed the challenges in a bunch of other areas. And that's going to take a long time to get sorted out, however quickly we come out of the pandemic. Jane, can you move to the next slide?
Yes.
Great, thanks. So this is what I was going to just go through with you, some talking points, and you'll put some questions in as well. I'll start with these, and as I'm doing this, I'll try and multitask, and we'll also look at the Q&A. So I've told you a little bit already about COVID-19 and its implications relating to kidney disease. So there's a lot of people who've had kidney disease as a consequence of COVID-19. Now, what we know about that is people who've had complete kidney failure. The large majority of those people who've had complete kidney failure, sadly, have died. And they've not died of the kidney disease itself. They've died of the fact that the body's been overwhelmed by COVID-19. So the initial reports that were coming out of the big intensive care registries, where we collect all the intensive care data in the UK, showed that of that initial group of people who were on the intensive care unit, also requiring dialysis treatment for acute kidney injury, that is the kidney suddenly stopping having previously had good kidney function, 4 out of 5 of those people died on the intensive care unit. We then know that people who did get through that terrible illness, that the large majority of those people, their kidney functions recovered. What's not known now is what the impact of COVID-19 is on the long-term kidney function at a general population level. So I'm sure that people who are on the line will have heard about long COVID, these syndromes that occur in the weeks to months after a COVID-19 infection, and have been compared to what we call other post-viral syndromes, where people get a bad virus infection and then can have really severe long-term consequences of that. We do think that some people with COVID-19 will have long-term kidney damage as a consequence of COVID-19 as part of that combination of problems that cause long COVID. But it's not really clear yet what the numbers are going to be. So that would be something that will become increasingly clear over the next few years or so. What is really clear, however, is that for people with a pre-existing kidney disease, that for people who've had COVID-19, for many people who've been affected, the implications of that have been really severe. And we know the implications have been severe because what we've done is collected all the information about everybody with kidney disease who is being treated either with dialysis or with a kidney transplant, and matched that up to COVID-19 infections. And that's allowed us to map really accurately what's happened. And that's driven a lot of what we've had to focus on at the community level. We've really tried to get our dialysis units and our kidney services as safe as possible. We've tried to get our kidney transplant services as safe as possible. Can you show the next slide, please, Jane? And one of the things to alert you to around that, and you might want to go and have a look at this, this is in the public domain, is to think a little bit about how health systems work to direct how care is provided. So, you know, I'm a healthcare user. I go to see my GP. I have medical problems that I need occasionally to get some specialist care for. And what I really want to know in that sort of situation is what are the implications of the problem that I've got? How many other patients have that problem? What are the trends with that? Well, we collect information about that in the UK in a long-standing registry called the Renal Registry, and that's part of the Renal Association, which is the professional body for renal healthcare professionals, doctors and other healthcare professionals. And the Renal Registry data was crucially important for our ability to recognize the implications of COVID-19. And if you go to the Renal Registry website, you can just search that out. What you'll find is you'll find all the reports for the impact of COVID-19 on people with kidney disease, where the results are coming back into the registry. So that's everybody on dialysis with a kidney transplant, and is also people from some centers who have less severe kidney disease. And that provides very accurate information. It also provides geographical information as well. So you can look at your individual areas and you can say, okay, you know, there was this much problem in Exeter, and there was this much going on in Dorchester, and what about in Manchester? So you can look at the differences, and those reports are being issued in real time. So they're coming out 2 weekly. I've put this particular slide through to the 9th of September, but there are reports on COVID-19 and its impact on people with kidney problems coming out regularly and are regularly being updated. And that's gave us some really, really stark early signals. Can you show the next slide, please, Jane? Really stark. If you move on a few slides, actually, Jane, go. I'll tell you when to stop. And again, and again. There, good. No, back one. That's great. Showed some really stark early signals. Now, this is called, we've got all of us have got a lot more used to the use of statistics in this material, but this is called a survival curve. It's called a Kaplan-Meier survival curve. And what it does is, if you look at the left-hand vertical axis, it shows you the percentage of patients surviving. And if you look at the bottom axis, the horizontal axis, it shows the days. This is a survival curve for over 14 days of people receiving hemodialysis in the UK following a COVID-19 infection. And you can see that through COVID-19, if you develop COVID-19, you're receiving hemodialysis, that you had a 20% chance of dying as a consequence of COVID-19 infection in the 2 weeks following that infection. And we got this information pretty early on, and it was coming back to us by anecdotal reports for renal services, but we were seeing this information and we were lobbying hard to be able to influence our ability to protect people receiving hemodialysis and people who are on the call who will be receiving hemodialysis, who recognize the extreme precautions that have been made around dialysis care in this period to protect people as much as possible. And there's very, very good evidence now that into the second wave, that's being very effective, that we're seeing a lot less infections as a proportion of the population than we saw through the first wave. And indeed, the outcomes are much better this time round. Now, there are a number of reasons for that, one of which is we're picking up people with asymptomatic or mild infection that wouldn't have previously been the case, firstly. But secondly, we're better at treating COVID-19. I've been working as an acute physician in some of my work at the Queen Elizabeth Hospital and treating people with COVID-19 as they're coming in. And there's no doubt that dexamethasone in particular has a substantial impact. That's the steroid which the big British study showed was effective in lowering the risk of bad outcomes with COVID-19. There's no doubt that the dexamethasone treatment, together with antiviral treatment for people with less severe kidney problems, you can't use the remdesivir antiviral with people with more advanced kidney disease, but with less severe kidney disease, it's having a big impact on outcomes. Could you go back then, Jane? I think this is working quite well, Jane. You'll have to come and do this on a few more of my talks. If you go back a bit further, sorry, go back. Yeah. Sorry, Yeah, and again, and again. Yeah, good. So as a kidney community, and this is just to give you a feel of what we did. On the left there, this is the first national call that we set up of professional groups, the patient groups of the key organizations within the NHS dealing with people with kidney care to really direct what was going on. And those calls continue to happen. They've become far more briefing calls now. We're still running those calls at the moment on a monthly basis, but we have a weekly leadership group in renal services that each week will identify what our priorities are, and people are working long and hard. And you know, I paid real tribute to my colleagues who continue to work long and hard in this period when you've got people arguing very strongly for what we need to do around the rollout of vaccination, the prioritization of people with kidney disease in this particular period. You show the next slide, Jane. And this gives you a summary. So this, I don't want to look at the detail of this, but this just gives you a summary of the structures that we put in place that drove our ability to be able to provide as accurate care as possible. And patient partnership was really at the center of this, that there was patient representation across the groups that we put together nationally. And there was incredibly close working between the professional and the patient groups and the NHS specialized services. One of the things that was put in place through the first wave of the pandemic was what's called regional networks for renal care. So those are people who were specifically focusing on what was going on in particular geographical areas. And that allowed us to be able to facilitate renal services helping each other during that period of time. That has now, we've been told that's going to be sustained. So there's funding coming through to continue that regional network model. And we're really going to use that model as that develops. One of the things that we did as per the professional bodies, the Renal Association, British Renal Society, is that we put the program, quality improvement program managers, who are a great group of healthcare professionals who work specifically improving and implementing patient care across the UK for kidney disease. They went and worked in those networks and brought their expertise in there. So we had a great deal of coordination. What you see around the outside is some of the outputs, some of the very practical things that were done in this period. And we've been advising SAGE, we've been educated, and your colleagues across the country, we've been bringing in data together, we've been producing guidelines, we've been driving clinical trials, and we've been trying to influence the models of care as they develop, very different models of care in this period. We're going to talk a little bit about that shortly. Okay, can you show the next slide then, Jane? Thanks. And one of the ways of getting a sense of what's happening is to use the website. So the Renal Association website has got a COVID-19 page with a lot of resources that people can get to. You could be redirected to that from the British Renal Society website as well. The core website, the patient groups have worked together amazingly in this period and have focused on a fantastic internationally recognized patient information resource, which is hosted by the Kidney Care UK, by Kidney Care UK on their website. And that's being updated virtually daily because the situation continues to evolve. So if you really want a granularity of detail that's relevant to you and support that's relevant to you, that's being adjusted and developed in real time, then do use that resource. I know that many of you will be doing that already. Okay. What I suggest we do then is just hold it there. Now I must have a problem with my yeah, I'm just trying to see if I can see the QA, or am I yeah, let me get in. I can't, I think I've just got a generic screen problem here, Jane. Jane, could you open the Q&A so that people could just see what questions are coming in, do you think? Are we able to see that from your screen?
No, no,
yeah.
Paul, are you sure? It's probably just close down because you roll your mouse around the edge and it should pick it up.
Yeah, I have.
Do you want, hi, it's Tess. Do you want me to?
Yeah, Tess, that's great.
Okay.
Tess, do you want to, is that all right? Do you want to pick out some
no problem.
questions?
No problem. We'll start with some of the early questions. So what evidence are you seeing on the impact of COVID on eGFR?
Yeah.
The assumption is that kidney function might deteriorate during an infection. Are you seeing function return after the person's got through that? And how long is it taking to get back to previous pre-COVID level?
So we don't think COVID itself is taking the kidneys out as a disease-specific thing. That statement may be wrong in the longer term. It's too early to say. So in other words, does COVID infect the kidneys so kidney function goes down? No, we don't think we've got strong evidence to show that that's the case, and that's not the case with other viruses. So flu doesn't affect the kidneys directly. The reason the kidneys go off when people get a bad COVID-19 infection is because people get sick generally. So when you get sick generally, the kidneys are one of the earliest organs to get affected. So if you get a bad infection and you drop your blood pressure, you become dehydrated, then the kidneys often go down as a consequence of that. And we call that acute kidney injury, that decline of kidney function. And the worse your kidney function, so if you've got chronic kidney disease due to polycystic kidney disease, you're at higher risk of acute kidney injury, because the worse your kidney function, the more sensitive what remains of your kidney function is to getting an acute illness. There's no evidence to show that as yet that COVID-19 has caused an overall major problem in kidney function outside of its impact on acute kidney injury. So kidney function does come back, and when it comes back from acute kidney injury, in about half people affected, it comes back to its previous levels. And then in about 90% of people, it comes back towards its previous levels. About 1 in 10 people will have a big hit on their kidneys. Time will tell whether COVID-19 will have an impact on eGFR at a population level. It's too early, and we'll report back on that one. I suspect it's going to be a good 12 months or so before it's clear whether it has got that level of impact. Okay.
Right, a couple of questions about impact of COVID on different stages of CKD and or PKD. So early stages 1 to 3, and then there's a couple of questions about stage 4.
Yeah. The risk of COVID in kidney disease is directly related to the severity of kidney disease. So kidney disease itself won't increase your risk of getting COVID-19. But what it will do is increase your risk of having a worse outcome if you do get COVID-19. So I showed you the graph of what happened in the first wave to people who were on hemodialysis who got a COVID-19 infection. And people on hemodialysis are the highest risk group when they get COVID-19. People who've got kidney transplants have a lower risk than people who are on hemodialysis. And people who are on home therapies, the risk to those individuals is far lower because they're far less likely to be exposed to COVID-19 because they're far easier for people to shield. But the risk of COVID-19 directly relates to the degree of kidney impairment that you've got. So you have a bigger risk of doing badly if you've got chronic kidney disease stage 4 than you've got chronic kidney disease stage 3A. Of course, you know, medics, and I'm being guilty here of the typical medical thing of saying, what does doing badly mean? Well, it means the worse your kidney function, the higher the risk you have of dying as a consequence of a COVID-19 infection. It's really, really important to give a caveat on that, though, because the actual risk for any given individual, including people with chronic kidney disease, is relatively small and is going down. It's just that major difference between younger people with no kidney disease and older people with kidney disease. So in the same way that some of you will be familiar with your doctors saying that, look, actually, the problem with kidney disease isn't a problem of kidney failure in itself, because there are treatments for kidney failure with transplantation and dialysis. The problem is the risk that it provides elsewhere, such as the long-term risk of increased risk of heart attacks and strokes if you have kidney disease. And there's a similar challenge then with the increased risk associated with infections when you have infections, including COVID-19, the worse your kidney function is. Some of that is because the immune system doesn't work as well when you have more advanced kidney disease. Some of it is because people who've got more advanced kidney disease have other medical problems, which also lead to increased vulnerability. The classic one, of course, is diabetes. We know that people with diabetes have had a major increased risk in this period of time. So I hope that covers some of that question.
Mm-hmm. Okay, a couple of questions about having very low kidney function, not necessarily on dialysis or transplant yet, but worried about children who are at school or coming back to home at Christmas, and whether these children should have COVID tests. Obviously, the parents are concerned about the children's health, but also about their own health.
Yeah, I think that's a great question, and there is no simple answer to that question. We've all got to do our own individual risk assessment on that. If you've got very elderly relatives, if there are people who are on the webinar today who are particularly vulnerable because of health problems, if you're potentially exposed because you've got young kids in the family who may be going to school, I think one has to make really difficult but careful choices, particularly over the Christmas period. I think this year it's all about minimizing your individual risk as much as you possibly can, and accepting that it now looks, which is great news, it now looks as if we genuinely have a way out of this, and that we may be looking at within 6 to 9 months being in a lot better position, and a lot of the brakes that we've currently got on the way that we can function as individuals and as a society being taken back off again, because the vaccines really do appear to be very potent and give us an opportunity for the large majority of people to have a successful immune response, which means they'll be protected against the virus. So I think you've got to individualize it. You have to look at your locality. You really have to. I'm sitting here about 3 miles out of the middle of Birmingham, and there are many areas of Birmingham which are real hotspots for COVID-19. And patients who I'm looking after, I'm saying, look, I'm really sorry, but your grandkids are going to school. Don't have any contact with your grandkids at the moment, because if you look at the schools in Birmingham, and I know this because I'm in Birmingham, people in Birmingham will know it, but people across the country won't, and I won't know what's going on in your localities. But there are schools which have had outbreaks of COVID-19 and have been shut in this current period in Birmingham, or years in the schools have been shut. How that would be happening in your own localities to greater or lesser degree, and you have to have an awareness of that. The big challenge here, of course, is that there is a lot of asymptomatic infection. We had I don't think I'm breaking sort of too many confidences here, but there have been patients who've been called in for kidney transplants in the UK who've been fit and well coming in, and they've had a positive COVID swab. And the transplant hasn't gone ahead. Why am I telling you that? Well, I'm telling you that to remind you that a lot of infection continues to be asymptomatic, including in people with kidney disease. Therefore, you've really got to be careful in terms of identifying for yourself as an individual what the level of shielding that you should be adhering to in this period. So you need to individually risk assess. you need to talk with your healthcare professionals. I'd urge people who are at higher risk to be very cautious in this period and almost say, look, actually this winter is going to be tough and challenging. Let's just work the way through it. But there's genuine promise now that we're going to come out the other side. Actually, with that point, can you flip on a slide or two? And I'm going to say, just in case we don't cover it, because I think you might be interested in this as a group. So that's fine. Yeah. If you go back.
Yes, there are a lot of questions about vaccines.
Yeah. So I've got three vaccine slides. Okay.
Okay, great.
So this is COVID-19. This is a sort of, I think it's from the NIH in the States. This is a sort of, it's incredibly beautiful actually, like a lot of biological structures, isn't it? It's a sort of the structure of COVID-19. The structure of COVID-19 is very similar to the structure of other common, previously common viruses that are far less problematic, such as common cold viruses and so forth. If we go on to the next slide, right. So there's 300 plus viruses in vaccinations in development. There are 16 vaccines at least in phase 3 trials. Phase 3 trials are those very large randomized controlled trials which give gold standard evidence. And those trials are now reporting. And we've now had 2 vaccines reporting as having incredibly high efficacy for preventing the development of COVID-19. And that's the Pfizer vaccine and the Moderna vaccine, and the AstraZeneca vaccine, which is the big British vaccine that we often hear spoken about on the news. That's pretty close to reporting in terms of its outcomes. You'll have heard that it's an incredibly powerful vaccine in terms of immunity. The reason I'm showing you this slide is that vaccination technology has moved on a lot in the last few years, and there are different ways in which vaccines can be produced. So if you look at this pathway here, the first pathway, number 1 at the top, that's the way that the Pfizer and Moderna vaccines are being made. So they're being made by using structural changes of very small coding segments within the virus. And they've been adapted, and people are being given that in vaccination form, and are then mounting an immune response that is getting antibodies, which you see on the right, which are against proteins that come in if you get a COVID infection. So it's prepping the body to believe that the body has already had a COVID infection. It's that classic thing, is if you've had if you've had a previous infection of a particular sort of virus, then you're usually immune against that infection going forward, because your body's got a memory of that infection and therefore it can wipe it out. So on the right side there, we've got antibodies, and antibodies are those circulating proteins that are the first line of defense, not the first line of defense, but the adaptive line of defense against infections. But also, and it's not on this particular slide, there's a lot of talk about T-cell immunity as well. And that's probably as important as antibody formation. And there'll be more information coming out around that. And people are working very hard in the UK. We've got large scientific groups looking to see whether or not you can track immunity against COVID-19 by measuring the numbers of T cells specific against COVID-19 in the bloodstream. So there's likely to be at least 2 different tests that will tell you whether you're immune. One is the antibody test, the other is the T cell test. There's no doubt that antibodies levels can drop with time, and it's not clear as yet as to what the antibody drop is. What is clear in the vaccination studies is that you need repeat vaccination. So they studies based on, to my understanding, 2 vaccinations, because there's fall-off after the first and then a second is given. People who are on the call, there's some people on the call who will have had hepatitis B vaccination. You'll remember that when you have hepatitis B vaccination, you have the hepatitis B vaccination, and then often you have 2 further vaccines that are given subsequently. And you can compress timing between that vaccination. So you can often give a vaccine at day 0 and give another vaccination 2 weeks later and give another vaccination 4 weeks after that. So there will be multiple vaccinations, but those vaccinations will occur relatively short time to each other. At the bottom there, 3 is the viral vector approach to vaccination, and that's the AstraZeneca one. Okay, so remember that these vaccinations are being produced by one of 3 main pathways, which I've shown here. The great strength with the AstraZeneca vaccination is that it can be rapidly upscaled. So they can make a lot more of that vaccine more quickly. So on a global basis, it may well end up being a far more used and useful vaccine. And it'll be, fairly predictably, it'll be a lot cheaper than the American vaccines, the costs of that. So in terms of being able to deliver immunity out into low and middle income countries, it may well be that the AstraZeneca will be the most effective one from that. You remember the AstraZeneca study was paused about 2 months ago for a short period, because I think one of the first 350 patients who received it got a central nervous system problem called a transverse myelitis, which means they had an inflammation of the spinal cord. And that was probably, it was felt to be coincidental, and it almost certainly was, because there'd been no other safety signals that come out of that. But people are watching the safety profiles of vaccines very carefully, because there is a possibility with some vaccines that there will be cross-reactivity with the ability to be able to cause autoimmune disorders, where your body actually gets tricked by the virus into turning back in on itself and causing problems with other organs. So if you go on to the next slide then, Jane. And so so this is actually there's probably copyright on these, so I'm sorry, but they're actually in papers. But at the top left is the Pfizer, and the bottom right is the Moderna. The Pfizer vaccine, so kidney-wise, the Pfizer vaccine, one of the problems is it needs to be stored at -80 degrees. And so we're currently thinking very quickly about how do we get those sorts of, that capacity to store at that level of freezer into renal services, in particular dialysis units. And on the right there is the Moderna virus, which actually is stable, is probably stable at around freezing point for a period of time. So these are the first 2 viruses that look as if they're moving through towards getting FDA, European Medical Agency, and MHRA approval. And it may well be that there'll be vaccination that will start before the end of December. If you look across the UK, there's huge efforts going on with local and regional teams putting in place an infrastructure for vaccination in general practice hubs. We're thinking long and hard and lobbying hard at the moment. Donald O'Donoghue was talking to Chief Medical Officer 2 or 3 days ago, really emphasizing the importance of getting the vaccinations into patients on dialysis. So that's vaccination. I guess any questions around that come up?
Yes, there are several to do with, well, whether any of these vaccines will be safe for kidney patients, particularly those after transplant, or those with on dialysis or with very low kidney function. Yeah,
they'll be safe. They'll definitively be safe. The AstraZeneca vaccine has got a live vector. So you remember the questions, but it's not a live attenuated vaccine. Okay. What we do need to know is what's the immune response in people who receive vaccines who've got kidney failure, including people on dialysis. We're trying to set up to get that information quickly. There's been a lot of work done with several renal services having measured antibody response to COVID-19 in people with kidney failure, including people on dialysis. And I can report back that people get a very good response. So you do get COVID-19 antibodies if you've got kidney failure. And we are seeing people get infections the second time round who previously had infections. We know that because people are getting swabbed a lot more frequently. This is people on dialysis. But it does look as if those individuals, if they get reinfected, are protected because they've had a first infection. So there's good evidence that immunity to COVID is a sustainable immunity. What we really need work on is to understand what the immune response is like to the vaccine, so that we can then map out how frequently people need to be vaccinated. And there's a lot of work to be done to look at the relationship between the antibody levels, that is the response to the vaccine, and subsequent infections. But the vaccines are safe. There's big.
Well, a question emailed over pre the event regarding someone who was is post-transplant and therefore immunosuppressed, sort of concerned about how the body would how they would respond because they're already immunosuppressed, having after vaccination.
Yeah, so that's a really interesting question, Tess. In fact, once people are out of the early stages, so the biggest risk with transplantation is an early risk because the big immunosuppression treatments happens early. And if you look at the overall risks of transplantation in terms of infection, the big risks are in the first 6 months of transplantation. And during that period of time, you can see a range of infections which reflect suppression of the immune system, such that you can get infections with things that usually the body gets rid of, such as fungal infections and some certain viral infections. After that, for people who have got a long-standing kidney transplant, the actual immunosuppression for people longer term is actually pretty low immunosuppression. And there's some evidence to show that there's a bigger risk of people who are receiving dialysis treatment who haven't got transplants from infections than there are for people who have transplants. So I think it's about your individual immunosuppression. If you've fairly recently had a transplant and you've got higher immunosuppression levels while the kidney's bedding in, it's a very different situation to somebody who's had a transplant 3, 5, 7 years ago and is actually on relatively modest levels of immunosuppression, because you will mount a really good immune response to the large majority of infections that you get. The challenge with a transplant in infections is recognizing early that you've got an infection. That is, you get medical attention quickly if you've got a hint of an infection so that it's treated, because it accelerates more quickly if you get one. But there is an immune response. And, people who have transplants and are immunosuppressed will respond to vaccination. What we do need to know is what the level of response is and what the frequency of vaccination will need to be to continue to have a strong immune response. The fact that there are so many vaccines being developed is a great thing, because it may well be that there'll be mutation in COVID-19 so that certain vaccines will become less effective with time. And you can see how people may end up receiving vaccines from multiple types of COVID-19 directed vaccines. This is a complex area, but it's safe. There's a big gap here, because this has all happened so quickly that we haven't yet got the information that shows us what the response is. Where we do vaccinate, and the one that we do use, of course, more frequently than any other. I mean, we use pneumococcus and influenza A, but the big one is hepatitis B, and we know that people, the large majority of people on dialysis respond to hepatitis B vaccination, and people who receive transplants respond to vaccination as well, but need more accelerated and heavier vaccination protocols.
Yeah, Paul, this person would like your thoughts on whether PKD patients at all levels should feature on the priority list for receiving vaccination.
I mean, that's just, so if you saw my email box over the last 2 or 3 days, you'll have seen this is a top line level of conversation that's going on. We have, and you can see it on the website, in fact, we've put an enormous amount of work into advice and lobbying around screening. We're now putting a lot of work into defining the criticality of early vaccination for people with kidney disease. For people with polycystic kidney disease, it depends on a number of things. The top line is, if you're receiving dialysis, we're going to be pushing incredibly hard for early vaccination. We've seen a provisional list of prioritization by the government, and that list of prioritization by the government is based upon, it starts off with people who are very elderly in nursing homes, because clearly they've been at highest risk in this period. And then it's age stratified, and it's then age stratified with other healthcare problems. At the moment, they're not picking out individual disorders in that. And our job in the next 2 to 3 weeks, before the vaccines become available, is to lobby hard so we have a really clear steer on the importance of people with kidney disease getting vaccinated. If you look at that phrase, clinically extremely vulnerable, well, at the moment, clinically extremely vulnerable applies to all people with CKD stage 5, irrespective of whether they're on dialysis or not. And then it'll depend on your age and your the presence of kidney disease before that. So it may be worthwhile looking at that list, because that list will guide what we will do in terms of lobbying. This is all about the risk to groups of people at an individual level. The risk to somebody with polycystic kidney disease and an EGFR of 30 who's 50 is in fact probably very low from a COVID-19 infection. Whereas the risk for somebody who's not irrespective of age, but is over the age of 50 and is in end-stage renal disease, either dialysis or transplantation, at the top will be dialysis in terms of risk, but transplantation will also be a significant risk as well. There's clearly going to need to be a prioritization in relationship to risk that relates to your level of kidney function. So it's about your own individual level of kidney function. It's about knowing that, and it's about talking with your docs and your kidney teams to get a steer and watch this space, because we're told that we may be starting vaccination programs in the UK before the end of December, and therefore the exercise around prioritizing is going to have to be really accurate between now and then. And we're looking out for, working with the patient groups, but looking out for you collectively and doing our best to ensure that you're prioritized.
Typically, putting a vaccine to market takes considerably more more time than this has done. From a sort of professional point of view, do you have any concerns about the sort of speed in which it's been accelerated? Although it's exciting, do you have worries about that?
No, because the numbers of patients who've been enrolled are huge. Tens of thousands of people have been enrolled in the trials. The clinical trialist approach to the vaccination studies has been incredibly robust. The level of scrutiny that the designs of the studies are coming under is intense, because everybody who's got expertise in clinical trials internationally, that is the big clinical trialists who run the clinical trials units, are looking very carefully at the methods that are being used and looking at the numbers of patients who are being enrolled. The top line, of course, is always always safety. The sheer numbers that have been assessed in this period with the early vaccines are really reassuring, in that there's no safety signals, major safety signals coming out. If you look at the AstraZeneca AstraZeneca vaccination, I think about 40 to 50% of people get a post-vaccination, mild post-vaccination symptoms with a bit of ache and pain, and sometimes a mild fever, such as that you'll get with you get with your flu vaccine and things like that. But these studies are being done incredibly rigorously. Organizations like the FDA, the MHRA, the European Medicines Agency are putting all their resources and teams into assessing both the safety and efficacy of these vaccinations. So all, there's a hell of a lot of scientific resource internationally gone into this. And I think there's, real credibility with the processes. We've got to come out of it with, we are coming out of it with really high quality vaccines. Vaccination is not usually a priority for pharma because it's not revenue generated. They don't get much money out of vaccination, but because of it's sad to say, but clearly with need for global vaccination for COVID, that becomes a very big market, and therefore you've got a pharmaceutical company focus, the likes of which one hasn't seen before, firstly, and secondly, you've got all the major academic centres who've got the ability to develop vaccines also involved, and often doing it in partnership. And the Oxford AstraZeneca partnership is a very good example of that. No, I think we've really got to be definitive that the processes and pathways here are credible. There's some talk, and you've heard some people say it, some experts say it, that there is a certain degree of pragmatism here. If you look on a population basis, are we better waiting for 6 months to just make sure and confirm everything's ticked off vaccination-wise in terms of, safety and efficacy, and we've got everything lined up so that we can find both the most efficacious and the safest. If you look at the risks, balances, benefits associated with that, there's more risk associated with that than there is going early because of the number of deaths that we see happening with COVID-19 and the likelihood that's going to continue while we still have substantial amount of COVID-19 circulating in the population.
Do you think there are mixed views within the sort of within on the clinical side? And there's a lady here mentioning that she's been advised by her transplant team not to have COVID vaccine until further research has been done.
Yeah, I think so. I'm a bit, I don't want to get into individual services, but I'm a bit uncomfortable with that sort of statement. I think that the clinical teams have a duty of care to be a lot more careful in their communication than that. The clinical teams should be putting patients in as safe a place as possible around decision making, around vaccination, and that involves, and we've been encouraging local kidney services to communicate as clearly and as effectively as possible through the pandemic, and some have been doing that really well. You have to be really careful with, and people who are listening know this better than I do, is that you'll get different stories from different healthcare professionals, and often that can be pretty loose, and people can provide, inaccurate information or advice based upon perhaps them not wanting to expose limitations to their own knowledge base. It's about what is the view of your service, and your service's view will be very much driven by what the national guidance is. And we nationally will be coming out very strongly and making very clear statements about the efficacy of vaccination. It's the time that it's specifically with transplantation tests. It is about the timing, because the problem with transplantation is that people early, it's not that it's a risk. It's that it might not work because of the immune response. And that's why it's back to what I said about 10, 15 minutes ago. We need to track the immune response in people who have transplants and get vaccinated. But people who've got several years out and on baseline immunosuppression, so people are on maybe on some tacrolimus with levels of 5 nanogram per mil, some mycophenolate and a small dose of steroids. That group of people, should get efficacy from the vaccines.
How are we doing for Anna? We're way over your scheduled slot, Paul. So thank you very much. One non-vaccine related COVID question that was emailed through. It's Jane, by the way. I'm surprised you got my northern accent mixed up with Tess before. She will
sorry. No, that's terrible.
She'll be horrified.
Sorry, Tess.
She's going to be really upset. So this person emailed a question in regarding how long COVID stays infectious. So in somebody that's been diagnosed as positive, that have gone through COVID and come out the other side successfully, has it then gone? Or are they still potentially infectious, is the question.
Yeah, well, I mean, what we think is that if you look at follow-up swabs, I think it's by 2 weeks, 95% of people are negative. But there are some people who get long-term, not long-term, but they will continue to carry virus for several weeks. That is, if they're re-swabbed, then you'll find that they'll still be COVID positive. But within that, there's a big difference between having had an infection that's better clinically and still having a positive swab, and having an active infection that's growing. So if you think about this in terms of the load of infection that your body's carrying, that also reflects onto the amount of virus that you as an individual who continues to be COVID positive put out there. If one really, really wanted to, at a population level, if one wanted to be careful about this, one wouldn't allow people to de-isolate until they had a negative swab. The timing around de-isolation is based upon where large groups of people have had follow-up swabs. The large majority of people with follow-up swabs are negative by 7 days, and actually by 14 days, there's relatively few. I think it's only a couple of percent of people are left, but there certainly is some evidence that people can, there are a few people who just carry it longer term and could be positive for many weeks with COVID-19 and be asymptomatic. But it's impossible to run a track and trace system on that basis.
So the assumption, therefore, is that if someone has recovered from COVID, that they are not necessarily they could still infect. Is that what you're saying?
Yeah. Theoretically, they can. Practically, it's unlikely, but theoretically, they can.
Fantastic. Tess, do you have any more questions? Have you got any more lined up?
There were just a couple, really.
Sorry, Tess, about the...
no problem at all.
I was concentrating so hard on the
I'm from the other side of the Pennines originally, however. I've lost my northern accent. There were just a couple of questions about care, kidney care. Somebody who's at stage 4, due to have a usual clinic appointment, told it was cancelled, requested a telephone consultation, now told they're only doing a few of these.
Oh dear.
Suggested to speak to the renal secretaries, would prefer to speak to consultant, hasn't said where, which clinic, which hospital.
Let me show you 4 slides really quickly, and then we'll deal with that. And because my next slides deal with it.
Yeah, and there was also a question about restarting a live donor transplant process, actually in Birmingham. But so if you want to cover when live donor, I know it varies around the UK, but
it's actually restarted in Birmingham. There's living donor transplantation going on.
So they should get in touch with the transplant.
It's happening. So this is a huge challenge, of course. So there's been rapid transition to multiple models of care. Most of you will recognize the telephone care that is become the commonest way of delivering consultations in this period of time. On the far right there, that's called virtual care. It's where the doctor just looks at your records and results in a system. And then you get your communication. You don't get your communication by telephone or video. Video actually doesn't work particularly well for reasons that people are working on. And then there's still some face-to-face consultation going on at the moment. but the large majority of this is done of consultation is being done as remote care. The next slides. Great. So this is, you'll be interested in this. Well, I'm interested in it, but I suspect you'll be interested in it as well as a group. Those answers there, these are from renal services across the UK. Okay, so this is over half of 72 renal services. 33 have answered this question. Since the pandemic, what type of patient-facing services are you offering for patients with non-specialist CKD? This is patients outside of advanced kidney care, low clearance clinics. Okay. And you can see that the proportion of face-to-face appointments is low, both for new patients and follow-up face-to-face appointments. And here's the thing that really is a profound concern. Is the next slide, Jane? If you just show that.
Oops, apologies.
Yeah. Okay. You guys know that, don't you? I mean, nobody. Yeah. So this is renal clinical directors answering on behalf of their services and tacitly recognizing that these changes have just come through. And if you just go through the next quickly through the next one and onto the next one, yeah. So here's the thing, of course, is that so this document in the middle of the year, this is the NHS Long-Term Plan, and this was released about just over 18 months ago, and this plan's really is pushing changing models of care. And a lot of those models of care are the models of care, or some of the models of care around remote and virtual care. And there's been an emphasis, or there's a central emphasis on trying to continue some of these models going forward. And I think that some of those models just haven't been properly evaluated, and we need to push back and understand what the right approach is. Now, again, it's difficult with individual renal services. I sort of don't want to individualize things here, but renal services should have a structure for, or should have worked hard to develop a structure for all areas of their service, which put people in a position where they feel that they're having safe care. Clearly, during this period, the high quality care that people should anticipate has often been undermined by the fact that many hospitals are now down to only being able to give around 20% face-to-face consultations. And that's been driven by the fact that you can't get, that's with distancing. You just cannot get people in to the clinic areas in the same way. But services should have developed an approach where it's clear to you, if you have kidney disease of any sort, what the specialist service is doing to support you, what your follow-up is, how you can access the service if you have a problem that needs attention, and a structure which avoids pushing people from pillar to post. And I know only too well that people find themselves going from one person on a line, secretary, to a nurse specialist who can't help, and not get anywhere near what they think they should be getting from that particular consultation or the particular healthcare need they've got at that time. And this, of course, is also a huge problem in primary care at the moment. So there's a few quick slides there, but just come back to that question there, Tess, that that somebody put in. Specifically, what was the specifics of that question?
Oh, it was, you mean the first one? So that was somebody who had been told that at very short notice that their face-to-face was cancelled, had asked for a telephone consultation, been told that they were very few of them, and that they should speak to the renal secretaries. They wanted to know about their blood results, so I guess they're not on Renal Patient View or any other portal.
Yeah, so we've had some. Birmingham University Hospital Birmingham, we've had that sort of story. And generally, if somebody, I had it last week, we've had to strip everything out such that a lot of people who are on remote, that is telephone calls, have at the moment gone to virtual care. What we have got in Birmingham is we've got community-based hubs where everybody's having their bloods checked, and then we've got a system with a good electronic patient record, which allows us to review everybody's bloods. We can inform people and say, look, things that look stable at the moment, and this is the plan for follow-up from here. There's a lot of temporizing going on at present. So the trouble with the second wave is that it's actually created more problems than the first wave. So renal services have been stripped out and have been asked to contribute to acute medicine in particular, because acute medicine is coming into winter months. So all unselected acute admissions to hospital, there are now a lot of renal medical staff, including renal consultants, working in those areas. And that means that there is less staffing within renal services themselves. So that model is a model that's running in a number of parts of the country. Clearly, whoever's asking is experiencing that. They may be from Birmingham, it may be elsewhere. I mean, my approach in terms of needing the CKD service in QEH is that if somebody says, no, I want a telephone, I'll just put them straight in for a telephone consultation. So, and in fact, so we have a system where actually if somebody says, I'm not happy with that, that's fine. And we'll bring people up for face-to-face if they need face-to-face appointments. The problem, though, is getting into this is how does one have a level playing field? So there's not inequity, because we know some people are better at representing themselves than others and making a case and getting through. And we really want to be really careful in this period of time so that people with kidney disease have proper access in. That may be around, I'm not sure if everybody on the who's looking in uses email. I mean, it could be around, asking your centre to ensure that there's a single email portal, and then that there's a standard of care for applying from that portal. And that's something I may push on nationally and ask renal services to think about that, and get a structure in place to put people in a better place than they are at the moment. I've got a lot of sympathy with the challenges that many of you are having in terms of accessing healthcare. Some of those are unavoidable, but the critical thing is that people are not exposed to risk in this period. And there are signals that some people are, not just in specialist services, but in primary care as well. It's a bit of a convoluted answer, but it is on people. It is on people's radar. It may well be worthwhile, talking to your KPA actually, and the chairs of the KPA know the clinical directors and should be working closely with them, and that message then should come back. We'll get back to the clinical services as well. And I can certainly, there's 100+ people on this. I can certainly put something out into the renal community through the clinical directors in the next few days, asking them to really focus upon ensuring people have access to the level of service that keeps them safe in this period.
Great. There were, on the plus side, there were a couple of positive experiences of telephone reviews and drive-through blood tests. So some things are working in some parts of the country. So.
Yeah, there've been some great exemplars actually, and it's about taking those areas which have been successful in developing their models, sharing them, and supporting those areas that are yet to develop them and getting them up to that level.
Yeah. Great.
There's also a positive story here of somebody who is 9 years post-transplant, experienced post-transplant rejection, and was also had COVID in April this year, and had a very quick recovery, and in fact rode their bike all summer. They want to tell us. So I mean, the strong message, of course, is that whether we're pre or post transplant, we are at risk. There's no point avoiding that, is there? But there are people who are coming through it, And I think so there's there are positive outcomes for some who get COVID.
Most people, actually. Yeah. The large majority of people with kidney disease who've had COVID have had good outcomes.
Yeah. Did you quote a percentage earlier, or did I imagine that?
So there's a percentage for dialysis, which is 80% of people come through, but the percentage is a lot better for people with less severe kidney disease. We don't know what we haven't got a really good feel for what the transplant figures are, because a lot of people with transplants who've had COVID almost certainly haven't been tested in the way that hemodialysis patients have. So we think quite a lot of people had mild COVID through the first wave who didn't get tested for it. Whereas for dialysis units, everybody was being tested, because once you got somebody with symptoms who tested as positive, then the rest of that unit was tested as well. So the information is far more accurate. So when the pandemic first came out, and this actually still applies, the risk for me of getting COVID, the risk for me of dying in the next year if I have COVID, or dying of COVID, is the same as the risk that I have of dying from any other cause in the next year. And so that's a rule of thumb. So if you look at any given individual as mortality risk, that is the risk of death of any cause in the next year, if you have COVID, it gives you that risk for that COVID illness that you have. Does that make sense? And I think that's quite if you get your head around that, that's quite a helpful way of thinking about it, because then you understand why, the risk of one of my, touch wood, one of my teenage boys coming to harm in the next year is very low, and they'll have a similar risk if they get a COVID-19 infection, where my father is very, very elderly and has had a stroke. And I've had this conversation with him, so you won't mind me sharing it with you. His risk of being alive in 5 years is not particularly high, and if he has COVID, he'll have a very high risk of not getting through, but it'll be the same risk for him in the next year if he gets it as his risk of dying of any other cause in the next year.
Okay, thank you. I think we've taken up enough of your time as it is. That's absolutely brilliant. Thank you. I think Tess is going to do a quick wrap up just before we say goodbye to our audience. Unless there's anything else you wanted to add at this point, Tess.
No, just thank you very much, Paul. That was very helpful. We also have 2 short blogs about COVID, which we've kept up to date and linked back, of course, to the Kidney Care UK information source, and and in particular, because we have patients from all around the UK, we have links to 4 countries' own websites on COVID, and we also produce with paediatric nephrologists a blog on ADPKD children and the impact of COVID or coronavirus on children. So although there is no evidence that PKD patients are more at risk, we're basically following the primary CKD guidelines, but we felt it was helpful to have one targeted a little bit at PKD, because we had so many questions in the early days from our PKD community that we thought it was a good idea to do that. But thank you very much for completing the information picture for us. That was extremely helpful and very timely, given all the news about the vaccines that are close to launch. Thank you very much.
It's a pleasure, and thanks everybody for who's on this particular discussion this afternoon. I know that there's a lot going on in people's lives, but it's great to see so many people touching base of what's a really important part of our journeys, really, isn't it?
Yeah.
Certainly is.
Thanks, Paul. That's absolutely fantastic. Thanks for giving up your time on a Saturday.